Welcome back, everybody. We are going to finish up with our last session of the day. And we've got a session with 4 panelists with us today, surveying the health equity landscape, current and future data-centric efforts and initiatives to address health disparities. And we've got Meagan Khau, office from CMS, Office of Minority Health. We have Rachel Harrington. I could have just reversed the order instead of going down the list. With NCQA, Jawanna Henry is with the Office of the National Coordinator, ONC. And on the end, we have Vanessa Candelora, who is with the Gravity Project. And I'll let you guys do further introductions of yourself if you want to as you go through your slides. But for now, I'm going to turn it over first to Meagan.
Thank you, Nancy. We'll go ahead and start it I'm Meagan Khau. I am the Director for the Data Analytics and Research Group within the CMS Office of Minority Health. So for this quick sessions, I'm going to give you a quick update on some of the data initiatives across CMS. This is just a snippet of what we do here in the Office of Minority Health with some update from the different components. And for those of you who are not familiar with our office, we are one of the 8 offices of minority health within the Department of Health and Human Services. So all of the work we do revolve around our CMS strategic plan. And the first pillar there, as you can see, is advancing equity. And so that there's been a lot of activities revolving that pillars within the last couple of years. As you know, we put out a number of regulations, guidance, RFIs, whatever you call it, we have it. And so for our office, we put out 2 frameworks in the late 2022, which drive a lot of the work that we have over the next 10 years. The first one there is a CMS framework for health equity from 2022 to 2032. And there are 6 priorities for that framework. And the first one is how to expand data collections, improve data collection, as well as standardized data collections. And the second framework, which was released the fall of 2022, focuses on advancing healthcare in rural, tribal, and geographically isolated communities. We want to make sure that there are certain areas of the country where we need to look a little bit more closer, so then underserved communities within those areas are not forgotten. And we also released what we call the white paper, The Path Forward, Improving Data to Advance Health Equity Solutions. The paper basically describes the current state of health equity data collection and consolidation across the CMS programs, details progress to date, and defines CMS future actions to continue the improvement of our data collections and achieve future visions of health equity data at CMS. As some of you may know, a lot of folks have been releasing data about CMS data, so we thought it's about time that we put out one on our own, and just to be transparent about the work. So what are some of the activities that we've been doing this year? We have been doing a lot in the areas of collecting race and ethnicity data at the disaggregated level. So some of you may be familiar with the OMB standards, where we have 5 categories of races and 2 categories of ethnicity. So the disaggregated level basically break down the Asian category with an additional 5 categories, I believe, and then the Native Hawaiian has another a breakdown of another 5 or 7 categories. So what has been happening is that all of our CMMI models participants starting this year will be required or has been required to report race and ethnicity data at the US CDI standards. And then for some of our post-acute care settings, we are also collecting race and ethnicity for 4 facilities, long-term care, inpatient rehab facilities, home health agency, and as of recent, skilled nursing facilities to start collecting race and ethnicity data along with 5 other social determinants of health data elements. And then we started to collect race and ethnicity on the Medicare Part C and D enrollment form starting this year as well. And then just recently, for the new marketplace application for this open enrollment period, November 1st, as of last week, we added the sexual orientation and gender identity questions to the form, which is for the 2024 open enrollment period. This is absolutely a big step for us. As we improve our data collection in trying to gather as much demographic information as we possibly can to implement Executive Order 13985, which is to advance equity. In terms of the social determinants of health data, as I mentioned, we started to collect for the post-acute care settings. The data elements there are for preferred language, need an interpreter, health literacy, social isolations, and transportation. And then the model, which I mentioned earlier, but we're also collecting SDOH in addition to race and ethnicity. And then our office recently submitted an element, SDOH data element, to be considered for the upcoming US CDI version, and that is, do you need or want an interpreter to communicate with doctor or healthcare staff? There's a lot of issues with health literacy, understanding, folks who don't speak English well, so we want to make sure that if there is a need, that it is captured well. And then another aspect of the SDOH is, as some of you may know, there are 2 SDOH measures that have been finalized, optional for this 2023 year, but will be required for calendar year 2024. And that is, some of the facilities will need to be screening for social drivers of health, assess the total age of patients, screen for social risk factor during inpatient stay, or during established care in the case of dialysis facility. The focus there is on food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. The second measure is to screen for the positive rate for social drivers of health. So if you screen folks as the first step, and then for those who you screened, what is the positive rate for those patients during the inpatient facility stay? So they were screened for all 5 of the factors that I mentioned there on the left-hand side, and you have to screen positive for 1 or more of those 5 elements. And then, so we are collecting data. So what are we doing with those data that we currently have? So in the Office of Minority Health, we have what we call Mapping Medicare Disparities tool that was launched back in March of 2016. It's an interactive map that allow users to identify areas of disparities between subgroups. So we started out with Medicare fee-for-service back in 2016, and as of recent, we added 3 measures for the Medicare Advantage data. It is stratified by race, ethnicity, sex, age, and it's downloadable data, and the basic data format is available in Spanish as well. So here's an example of what we added for the 3 measures for MA Medicare Advantage data in terms of hospitalizations, inpatient measure for discharge destinations, and inpatient stay. Due to, as some of you may, due to the quality of the data, we are starting out with the 2018 for these 3 measures, and we'll continue to update as we go along. The other new piece we added to the MMD tool is a social determinants of health tab. Basically, this captures a number of measures that we pull from publicly available data. This is not just for Medicare enrollees, but for all populations within the United States. We are not able to overlay the data because the population view only goes down to the county level. So as some of the speakers earlier mentioned, there's HIPAA rule in how far down you can go. So the SDOH data tab is able to go down to the census tract level, which is going to be helpful, but because it goes down to that level, we can't overlay it over county level data. So here are some of the measures that we use to add to this new data set, looking at ACS data, CDC places, the SVI, and ARC SDOH database. And for the SVI, here are some of the breakdown of what we're looking at: socioeconomic status, household characteristic, racial and ethnic minority status, housing types, and transportation. So this is the first of our work on this data set, so we'll continue to add as we go along. And then we've been putting out a number of resources as well. We did an analysis for SDOH Z codes for 2017 and 2019 Medicare fee-for-service data. We found out the utilization is super low. So for 2019, we have about 1.6% of data for about 33 million enrollees, so that sample size is so small. What we also realized from the analysis that a lot of folks do not know what Z codes are, how to report it, why it is needed, and so we put out this infographic in 2022, and we updated as of this June to make sure we capture the information and be informative in terms of why it is important to collect the data, to document it, to map it, and to use it. And then, of course, on the back end, CMS will have the data for further analysis. And then as of September, we recently put out this Improving the Collection of SDOH Data with ICD Z Code. Again, is another resource to assist providers with understanding and using the Z codes. And we appreciate the Gravity Project for supporting us in this work and promoting the infographic. And then for 2024, we'll continue to do the work that we've been working on, improving our current data collection and collecting new health equity data where applicable. I'll continue to update the Mapping Medicare Disparities tool and add new data set. Continue to release our outreach and education resources there to support our data collection, and as well as some of the other initiatives that I didn't get a chance to showcase here. The other two new things that we hope to do is to release an MLN training on Z codes, again, to support our data analytics as well as the infographics, and looking into analyze the Z codes for the new years. And the biggest thing we'll probably be working on, as some of you may know, is the new guidance from OMBs on the revisions of statistical standards for race and ethnicity. They released a federal register earlier in the year asking for comments across the country. Lots of people provided comments, more than 20,000 comments, and they're looking to provide and release guidance on the new standard by the summer of 2024. So that is going to be a lot of work for us as well as other agencies and our stakeholders. So we're anxiously awaiting to see what that standards will be. And here is our list of contacts information. If you have any questions, feedback, please feel free to reach out to our Health Equity Technical Assistant Program, and the email address is there. And so thank you so much, and I'll pass it on to Jawanna.
Great, thank you. Great, I'm Jawanna here. I am the Interoperability Systems Branch Chief within our Office of Policy at the Office of the National Coordinator for Health Information Technology. I'm going to get started by kind of giving you the big picture, and this is kind of the points I'll be making throughout my presentation today or my introduction. First thing I want to highlight is the policy of the administration and what we've been focusing on as federal government agencies, and that is pursuing a comprehensive approach to advancing equity for all. As we're thinking about addressing inequities, there is a role where data can support this by collection, documentation, reporting, access, and use of SDOH data. Our goal is to think about how we can advance the use and interoperability of health equity and SDOH data, and noting that it's important to public health, and it's important to be able to improve the overall health and well-being of all individuals and communities, and that all of that aligns with our vision at ONC for better health that is enabled by data. So I'll be talking about the role of ONC as we are charged with coordinating nationwide efforts in implementing and using the most advanced health information technology and electronic exchange health information. One of the things I like to highlight, I've said all of this and I gave you our vision. We do our work through several activities with a focus on some targeted impacts. Our activities include standard certification exchange, but again, that point of coordination, we do coordination with our federal agencies as well as the industry. And we do this with the focus through these two objectives, but our goal is to impact these different areas. You heard earlier today from our national coordinator, Mickey Tripathi, some of our areas of focus, and that include building the digital foundation, making interoperability easy, promoting information sharing, and ensuring proper use of digital information and tools. One of the things we like to highlight when we're talking about health equity and SDOH is our 2020-2025 Federal Health IT Strategic Plan. And this is one of the projects that ONC leads, but there's engagement from other federal agencies. There's input from other federal agencies. And it is a shared vision, and that shared vision is to reduce burden, promote interoperability across the healthcare system, as well as lower costs and improved care. So the idea is doing that work and achieving that through these four goals here, which is to promote health and wellness, enhance the delivery and experience of care, build a secure data-driven ecosystem to accelerate research and innovation, and that fourth goal is to be able to connect healthcare with data. The first goal is the goal that I want to highlight because under that goal, there is a strategy to advance standardization and interoperability of SDOH data, capturing and integration of SDOH data into the EHR. So you can go and take a look at that on your own time. In addition to this Federal Health IT Strategic Plan, we also have our HHS SDO Action Plan, and you see the three goals here, which is build a robust and interconnected data infrastructure. Goal 2 is about improving access to and affordability of equitable delivered healthcare services, and the other things listed there. And then goal 3, again, is that focus on adopting a whole of government approaches. So you can see here, when you look at the picture on the screen, you see this full social determinants of health ecosystem. You see the community impact, where they lie, and the individual impact. What I want to draw your attention to is just the objectives. Note that there is a role for addressing structural racism, addressing individual social needs, and addressing individuals' healthcare needs. If you look on the other side of this upstream and downstream picture, you will see that enhancing data infrastructure goes along that entire stream. And ONC is in alignment with this work, again, focusing on Goal 1 and Goal 3. ONC does this work, and what we like to have across our different areas of work is the approach to support interoperability. And so when we look at social determinants of health, we do this between data standards and data, policy, infrastructure, and implementation. From a standards and data perspective, we support advancing SDOH data and exchange standards and development. One of the things I like to highlight is the fact that SDOH has been included since our USCDI version 2 and is still being included up until the current version of USCDI version 4. From a policy perspective, I just mentioned our 2020-2025 Federal Health IT Strategic Plan, but we also have a role of encouraging people to adopt SDOH standards, and specifically for HHS use in regulation. Again, you heard earlier this morning our coordinator talking about how USCDI version 3, again, which includes those SDOH data elements being included in the proposed HTI Rule 1. And I do want to highlight, again, just the infrastructure and implementation spaces as well. And this is where we have the opportunity to work with our federal partners, work with states, as well as the health IT community on their specific interoperability initiatives, providing technical assistance. And then there's that role for implementation, and I'll get into some of the details of some of the work that we've been doing in 2023, such as our SDOH Information Exchange Toolkit, and our outcomes from that, and then talk about some work in the innovation space. First thing I want to highlight, I talked about standards and data. This is just giving you a snapshot of what the USCDI version 4 looks like. You can see some things that were added, some things that were changed, but again, just highlighting the fact that you'll see those SDOH data elements, and with this version 4, there was a focus on health equity related data elements. And now moving to this idea of infrastructure, offering technical assistance and implementation, I want to highlight our SDOH Information Exchange Toolkit. Now this toolkit, as well as our SDOH information forms, were developed based on information that we gathered in coordination with EMI advisors in a technical expert panel that we convened in 2021. And we heard from different partners on the challenges, the successes when it comes to SDOH information exchange. And out of those things that we heard, we developed the SDOH Health Information Exchange Toolkit. Within this toolkit, you will have information as it relates to the SDOH information exchange landscape. Just for your awareness, we have information about different approaches to advancing SDOH information. And we don't just share that information, but we provide you with examples of some of the common challenges as well, and some of the promising approaches in that space. And then there's also this idea of these guiding questions for that and within that toolkit as well. In addition to that toolkit, we provided you with this resource that you have at hand, but we also wanted to do kind of a deeper dive into some of the foundational elements that are included in that toolkit. So between 2022 and 2023, we had 9 learning forums that people were able to attend to, again, do a deeper dive into those foundational elements within the toolkit. And so here you'll have the link to those past recordings and then additional materials to support that work. And next to last thing I do want to highlight is our leading edge acceleration projects, which is also known as LEAP. These are projects that when we look at health IT, their goal is to advance the development and use of interoperable health IT by addressing emerging and future challenges. So in 2021, we have our focus on using referral management to address social determinants of health aligned with clinical care that was awarded to the University of Texas. You'll see the other area that was awarded as well. But then in 2022, we also awarded a grant to Alliance Chicago with a focus on addressing health equity and social determinants of health through innovative open source technology, tools, and electronic health records. And the thing just to highlight between those two projects is referral management, working with various partners to develop applications to support that data collection of social determinants of health. UT Austin is focused on food insecurity, while Alliance Chicago is focusing on the housing domain as we think about social needs. And then the last thing I want to highlight, because we talked about infrastructure and implementation, but there's also this space for innovation too, and coming up with bright ideas. And so one of the things that we thought about was the opportunity to look at specialty guidelines that include SDOH components and being able to analyze the alignment with those components to inform future work. And what that future work consisted of was taking those guidelines and the opportunity to turn that into clinical decision supports. And the feasibility of using CDS hooks. So we did that work. We developed a brief on that work that is available on our website. Again, it just examined the readiness and feasibility for engaging a cross-functional team, and that team consisted of providers, researchers, health IT developers, and evaluating those guidelines and then the different recommendations for SDOH, for CDS implementation. So those are just some of the projects that we have had going on for 2023. Looking forward to looking at some of those successes and challenges from those different projects. In addition to our work, we want to provide you with some additional resources of additional work that is linked to health equity and social determinants of health that are happening around ONC. But then we also wanted to provide you with some additional resources with our other federal partners as well. And now I will pass it over to Rachel.
Fantastic, thank you. So, hi, I'm Rachel Harrington. I'm a senior research scientist at the National Committee for Quality Assurance. Just to gauge in the room, show of hands, who's familiar with NCQA, either through accreditation, measures? Okay, awesome. makes things a little bit easier on that sense. So for those who may be less familiar, NCQA sort of holds a dual or triple role that I'd say. We have a standards accreditation role, mostly for health plans, but also patient-centered medical homes, some practices, long-term services and supports. We also have a measurement function. We develop and maintain the HEDIS measures, used again primarily at the health plan level, but also a variety of other use cases. And we also have sort of a field support arm, a research, contracts, grants, services arm that really tries to look at, through that other work, where are we as a field and where do we need a little bit more support, understanding how do we continue to develop there. And so what I'm going to walk through today is coming from that perspective. It's what we're learning on the ground through conversations with healthcare organizations, plans, providers, community organizations, how that's being reflected in some of the standards and measurement work, and then how that sits in the policy environment that Jawanna and Meagan have described in terms of our data infrastructure, our payment policies, and sort of our incentive structures. And for anybody who's in the quality space, there's this really common aphorism, what gets measured matters. And I think that's a really interesting framing to bring to equity and equity data as we think about what we are measuring. Does it matter? And is what we are learning matters on the ground being measured? So it's sort of a flip framing there. When we talk about equity data, and a lot of this has been discussed already, there's a whole realm of data points that we could be talking about here. A lot of it is demographics, race, ethnicity, sexual orientation, gender identity, disability status, so on. But there's also social drivers of health and also a range of experience and outcome metrics. We're starting to see the growth of things like perceived discrimination measures going into Medicare caps, for example, in the next year, that we need to be thinking about as data that needs to be exchanged and understood. There's also a variety of perspectives here. We're sitting here taking sort of a health system perspective or a policy perspective, but particularly for equity data, there's a really strong need to consider the patient, family, caregiver, and community organization perspective as well, because the way we define data and data points very frequently does not match up with how people outside of our bubble think about it. And there's also the process here. There's how you design the questions all the way up through how you evaluate and score performance. And each of those has some very particular considerations around the metadata that needs to travel with it, the interoperability considerations, and the users, who are the users there. So as I kind of go through this, I'm going to be focusing on what you see outlined. Primarily the demographic social drivers, a healthcare system perspective, and then focusing more on the data collection, management, evaluation piece. But I think it's always helpful to frame it this way to know what we're not talking about and what we may need to talk about in other forums. So starting off with demographics, and I mentioned this, there's a whole range of constructs that we kind of lump under the umbrella of demographics. Race and ethnicity is one that I think as a field we've been grappling with a lot over the last couple of years, but preferred language is another one, country of origin, sort of that cultural element that can bring a lot of insight into an individual patient or community's experiences, sexual orientation, gender identity, disability as well. And as we think about this, I'm going to talk through some considerations on race and ethnicity and on sexual orientation, gender identity, or SOGI data. But it's worth considering what are shared considerations here. Some of this, like data provenance, interoperability, categories, things like that's going to come up across these different domains. But there are also unique elements here around identity, around privacy, sensitivity, the policy environments that we're all working in. So as organizations, it's always helpful to not over-conflate here. And when you think about your data management strategies, when you think about your privacy policies, security policies, thinking about where these might differ by these different characteristics as well. So race and ethnicity data. This should be nothing new, but I find this 2023 survey incredibly enlightening. There was a systematic review of US-based healthcare databases, mixture of research databases, EHR, EMR databases, large claims data assets, registries, so on. And it was looking specifically at the completeness and quality of race and ethnicity in all of those. It was something like 56 databases total. Completeness varied between 42 and 99% across those databases. Only 27% had any evidence that the accuracy of the race and ethnicity data was being validated or evaluated. Disease registries had, on general, the most accurate data, while the private health system EHRs had the least accurate data. There were issues with differential misclassification. It wasn't that every population was as likely to be misclassified. The Asian, American, Indian, Alaska Native, and Pacific Islander communities were the most likely to be misclassified. But there was also very clear evidence that system-based interventions to improve availability and accuracy worked. So when they went and talked to the healthcare systems that were sort of behind in generating the data in the EHRs, and they said, oh, have you done any efforts to improve the quality of your data? And they were able to get those examples and track the longitudinal improvement and saw improvement. So it can feel hopeless in some ways that the data are so challenging, but it can be improved. And I think that's a very important lesson from this study. Now, when we flip that and we think about how we use that for measurement and reporting and using quality as sort of a use case there, the data on the screen comes from HEDIS reporting in 2021 using a descriptive measure we've had around for a number of years. And broken down by product line, you can see, again, wide variation in the completeness of race and ethnicity. Commercial plans have more work to do. Medicaid plans have a leg up. You can hypothesize. There's the enrollment forms there, make it a little bit easier. Medicare plans also had some work to do. And this is, I think, an interesting insight. This is the plan's own internal data. We know that the data sort of at the national federal level is in many cases much better shape. But this was the plan's own census of, oh, I have a value on this patient, meaning are they connecting it in? Are they looking at it in their own systems? Also, race and ethnicity, how you ask the question determines the completeness of the data that you have. Combined questions that only allow for one answer, you're going to explicitly and implicitly bake missingness into your data sources. We've also done some work trying to understand at the health plan level, how many data sources are there? Where is this race and ethnicity data coming from? This is a list, came from 2 different studies, tried to put it together and group it. And I'm not going to name them all here. I think it's fascinating in a variety of ways the creativity organizations are bringing to sourcing race and ethnicity. But what I will say underlies all of this is, if we do not have a way to characterize the source of where data is coming from, the recency, the time point, the categories that were used at collection, your provenance, your metadata, making sense of the 20+ sources on here is going to be impossible. And I think that's one of the biggest sort of calls to action that we have in the field of data and how data is being transformed into insights, is getting the metadata, the back end in order to allow us to make decisions on what we do with all of these different opportunities. We are seeing, actually, plans are starting to do this on their own. They're hacking together solutions. They're creating Excel files in the background that house all of this information. What source? What was the generation process? What's the update cadence? What values? How do you map between systems? Because of those 20 different sources, they're all going to have slightly different categories, slightly different questions. Some will allow you to select multiple, some will only allow you to select one. And so this mapping activity on the back end is an opportunity, but also a risk, misclassification, error, noise in what's happening. So that was race and ethnicity. That's challenging enough, but we're also now looking at sexual orientation and gender identity. And this is one where we know there are challenges, but also we sort of caution, and if you look at the literature on this, it's fairly clear, the perceived barriers to asking for this information can be a lot higher than an individual patient's own judgment of the barrier. There are a number of studies out there that say the provider's own discomfort asking these questions is higher than the patient's discomfort sharing this information. So again, challenging, but there are interventions, there is hope, are ways to improve this. Structurally, we're also starting to see a lot of activity in really raising the bar in how these data are collected. We heard some great examples coming from CMS and ONC in terms of the standards and in the marketplace, really baking this into the day-to-day data collection. On our end, we've seen a really interesting uptick on the Medicaid side. NCQA has a health equity accreditation where SOGI data is part of the accreditation, and it is now mandated, I want to say, in 14 different states in terms of Medicaid, and is getting picked up in state marketplace and ACOs programs as well. So we're seeing states who are willing to start, putting some structure behind collection. We're also getting to the point where we want to start using this to do a better definition of quality healthcare. 2 measures we recently updated in HEDIS were breast cancer screening and cervical cancer screening. Both of these are long-standing, widely used core set, stars, measures out there that traditionally were defined with a narrative text of women of a certain age, criteria based on guidelines. In the digital logic behind that, it was using administrative gender, women. If you think about it, if you've got a cervix, you need cervical cancer screening. Your gender has nothing to do with that. And so the development in data is actually allowing us to do more precise, more clinically aligned quality measurement as well. But we're working in an environment. So there's a tension here, and I'm sure everybody in this room knows it, between the most available data, which tends to be the least precise, and the least available data, the newer constructs that are really pushing the field forward and are more precise. So everybody's got admin gender, binary sex, which generally is gender. It's there. What it represents is unclear. You can have it change over time as part of your sort of prior auth case individual patient management. So what it means is unclear. There are a number of better options, sex assigned at birth being one. It's a proxy, but it's better. Sex parameters for clinical use is a newer construct coming out of the Gravity Project that's based on clinical observations. And then we're starting to see some of the EHR vendors actually get to the point of anatomical inventory. Do you have a cervix? Yes or no? And then that can guide your clinical decision making. So our goal as a measure developer, but also engaging with the sort of informatics field, is really to help push towards the more precise data, because at the end of the day, better quality, better healthcare, that's where we need to be. For time, I'm going to skip over this, but this sort of walks through, for breast and cervical cancer screening, the changes that we made, basically bringing in additional parameters to support more inclusive screening. I'm going to wrap up with a little bit on social drivers of health. The one distinction I think is always important to make here is that social drivers can be distinct from social needs. Social drivers can be community-level data, population surveys, and so on. If what you want is social needs, a patient's own identification of their unmet food, housing, transportation, so on, then that implies you have to collect it directly from the individual. And so that brings the question along with how is that data collected, how is it managed? We've done some initial work in terms of measurement here. The HEDIS measure on social needs screening looks at food, housing, transportation. It looks at screening as well as intervention for members with a positive screen. In looking at this, there's a whole set of questions here around standardization of how you're surveying for these constructs. Are you using standardized instruments that are linked on the back end to structured fields? Sort of leveraging your LOINC codes for the questionnaires, your SNOMED, and so on for the responses. And I think that is something where the field, and I think Vanessa will get into this too, this is a behavior change as well. A lot of organizations who might have been doing this screening and data collection, getting to standard questions can be a behavior change. Not just, do you have the informatics IT in the background to link to the data, but I've been using this question for 10 years and it works for my community. Why do I need to change to another structured tool? And so keeping that in mind as part of the transformation here. So looking ahead, where does all of this leave us? There are challenges, right? Categories, rationale for data collection, access to data, imputation is a big one that's sort of lurking behind all of this, particularly for race and ethnicity, and when you grapple with the level of incomplete data that's there. But I would say all of these are also opportunities specifically for the informatics field and interoperability field as a whole. How do we stay aligned in a rapidly evolving environment? How do we build trust, both in collecting and in using the data? And I think data standards have an immense opportunity here to help address these barriers, but also we have to be very cognizant of where coming in with a health systems mindset might also contribute to the barriers in terms of collection and identity and what that looks like. And with that, I will turn it over.
Thank you so much. Oh, hello? Okay. Thank you so much, Rachel. That was fantastic. What a great overview. I have so many exciting things to talk to you about. Okay. Oh, here are some wonderful resources by NCQA. All right. Hi, everyone. I am Vanessa Candelora with Point of Care Partners. I'm the Gravity Project Program Manager, and I'll first start out by just thanking my fellow panelists here. I think you all mentioned Gravity at some point, and we're just really excited to be here. I'm excited to be with you all, so thank you, and thank you, WEDI. How many of you have heard of Gravity, familiar with Gravity? Awesome, just about everyone in the room. So I'll be very quick. We are a collaborative, multi-stakeholder group of members that are coming together to develop and support implementation for consensus-driven data standards to support collection, use, and exchange of social determinants, social risks, and social needs data. We want to thank our project sponsors and members and partners in every presentation that we do. We could not do this work without the sponsorship of all the organizations that are listed here. We are open for new sponsors, so if you're interested, please reach out if you don't see your organization here, and also our in-kind contributions. We really think of our work in terms of 3 work streams. So when we talk about terminology, it is really supporting the identification through a consensus-based, evidence-based way to find face-valid screening instrument questions and codes that Rachel was talking about, and all of that data that is needed that Meagan and Jawanna were talking about for the initiatives that we're doing, as well as for the individual level of care. we do that in our terminology. So we're constantly giving submissions to LOINC, to SNOMED CT, to ICD-10 and 11, if you attended that earlier today, and HCPCS codes as well. And so all of these things come together to support the data that is needed to be able to effectively communicate what these needs are, both for personal level care as well as the structural changes that are needed. And then on our technical side, we are an HL7 fire accelerator. We have an implementation guide. We'll talk a little bit more about that. But a lot of what we do there is testing and development and driving adoption for the exchange of this data. And really at this point, given where the ecosystem is with social care data, it's the data model, right? So I think yesterday there were colleagues that were talking about, fire is a lot of things, right? Most people think of it as exchange of data. We're all very familiar with that. But there's also a really great element to the data model itself for storing that data. And that's a lot where some of our pilots this year have been. And if you're here tomorrow, come to the 2 o'clock session. We'll talk more about it. And then pilots, as we'll talk more about. So what did we do this year? Where were we in 2023? Well, we have now 19 social risk domains. When we say domains, it's actually very aligned with my fellow panelists. So housing instability, food insecurity, transportation insecurity are all long supported. I think we started with food 5 years ago. And this year we worked on digital literacy and digital access domains. So those are our newest with the support of Kaiser Permanente. Thank you, Kaiser. We are currently in Q4 of this year focused on what we're calling an IQR sprint, which is in support of the IQR measures. We were getting a lot of really great questions from people that were looking forward to that IQR measure and how to support it come January, as well as some of the NCQA Health Equity Plus accreditation. And so we're focused right now on supporting a little bit of work on consensus for utility and security value sets with existing terminology, and we'll plan to do some more work next year on that, as well as guidance on how to apply gravity screening best practices for intimate partner violence and elder abuse value sets, which we've already completed, but we found that there could be some more guidance based on implementation learnings. And so here to support that in an interpersonal safety domain. And on our technology side, we supported a update thanks to CMS and the team at MITRE to our standard for trial use version 2.1 now, publication in August, which improved a lot of the readability of the implementation guide for closed loop referral, as well as the data model and support within FHIR to make it a little more readable friendly and a little more aligned with the way a lot of the implementation guides work within HL7 today. And lastly, we completed a successful proof of concept test to help determine social care supplemental benefits. So using a MA plan, proof of concept in sort of a test environment, a person comes in, they have a need for a referral to another medical appointment. They say they don't have a ride. So the clinician was able to quickly look up if they have supplemental benefits as part of their MA plan for transportation rides. It turns out they have 12 rides available as part of their plan for medical appointments. They've only used 2, and so you can, retrieve a voucher for a transportation ride so that the appointment can be made without that added stress of figuring out how to get there. So that kind of use case was what was used there. And we leveraged the Vinci guides that were talked about earlier today for prior authorization, actually. So the coverage requirements, discovery, documentation, templates, and rules, and prior authorization support. I need to hurry up. Okay, we have a strategic goal for implementation and adoption. We've done a lot of really great work this year on implementation resources and support. So I mentioned the implementation guide. We developed domain-level question and answer value sets with appropriate codes, getting back to a lot of what Rachel said about people sort of picking and choosing what questions that work for them in their community. We now have the codes to help support that effort, as well as for some of the standard, Prepare and HRS and the other screening instruments. CCDA, inclusion of gravity SUH value sets into the 2023 CCDA release. We developed materials on our Confluent space to make it easier for implementers. And just most recently, we partnered with AMA to release a resource for documenting social risks related to the ACH health-related social needs screening tool that will help support getting from questions to conditions so that you can move forward with goals and treatment. And in our pilots work stream, this year, we're so grateful for our support for pilots and external funding from the Robert Wood Johnson Foundation this year in partnership with the Civitas Networks for Health to support our Tier 2 of pilots this year. That kicked off in April, and I'll talk a lot more with a colleague from Bronx Rio tomorrow at 2 p.m. around all the great work that they're doing in New York State to capture screenings and use the FHIR data model and all of the terminology from Gravity. But we also have a My Health Access where they are looking at a mobile app for patient reporting needs, coming back to what Rachel was saying earlier. University of Colorado is getting screening in their outpatient to support IPPS rules, and Pima County and a Southwest tribe starting to gather this data. And what we're really doing here is meeting the industry where it is, recognizing people are at different areas of their journey and capturing this data and exchanging it and using it to improve health equity and overall health. And we host a monthly pilots affinity group call, which is the last Thursday of the month. The last one will be November 30th, I think. We also did I feel like I'm about at time. Okay. We also did a social care co-design, again in partnership with Civitas through Robert Wood Johnson funding this year, a 6-session series with community-based organization representatives from across subgroups of community-based. We had all federally funded U.S. of Aging to reverends in faith-based organizations. You know, it was an amazing group of people. The bios are all on the link from this slide. But this is it actually should say draft. It's a very draft visual of a lot of the things that we learned are areas of need for community-based organizations and understanding the data and the activities that go into the work that they do. And it's very, lots of variation, but there's, again, what Rachel was mentioning, sort of person, family level activities, the activities that go into supporting individuals, and we note what we currently support within the Gravity standards, those existing use cases in the dark blue, and then some of the new areas that we could be venturing into. There's also the population community level, so getting this data standardized with interoperable standards across communities, right, is really challenging. We want a really community centric approach to this, but if we're going to be able to gather insights and improve our system to make sure that, Ryan Howells mentioned the screening is going to increase, right? But when that referral is made to a homeless shelter that has no beds left, what are we going to do? How do we address those systemic challenges? Well, we need the interoperable data to be able to support those interventions and improvements holistically. So this was a really meaningful, we're excited to build and continue on the work that we did here to solicit and synthesize that social care and community-based organization voice to inform our standards going forward. And with that, this is a lot of words on a slide. It is meant to be a summary of a very exciting list of opportunities, of activities for Gravity to have our members that are actively right now prioritizing this work moving forward into 2024. We will move at the pace of funding, essentially, but these are emerging themes in the blue box in the middle here that are potential new work areas for us that came from our Gravity members, our very large community of individuals, our terminology collaborative, our pilots and our implementations, our social care co-design, as well as HL7 work groups. WG is work groups, my apologies for the acronym. There are a few key themes to some of this new work. Social care payment and reporting is a huge area for improvement with standards and interoperability for social need and social risk data. Enhancements to assessments and referrals. That's a lot of the existing work that we've done, but we can build on that with holistic assessment support and not just social risks, but protective factors. Do you have a neighbor that you rely on, a family member that lives close, you're really close with your faith-based organization? Those are all protective factors that should be leaned into when looking at a care plan for individuals. Requesting additional information, and also chaining of referrals. So oftentimes a clinic setting may make a referral, and then that will then make another referral, and how do we close the loop on all of that and ensure continuation of care and a care team being knowledgeable about all the information. And then there's a lot of cross-use case, cross-work streams. This is not to say that Gravity is going to do all this work in a vacuum, right? We work closely with a lot of different organizations throughout the industry, and so those are some of our great opportunities there. Interventions, outcomes, and measurement, again, theme up here, something we all need to lean into a little bit more. And lastly, we have a number of more terminology domains that we'd like to build out the codes and words for. So we hope you join us tomorrow at 2 o'clock, whether you're in person or virtual. I'll be joined by Kathy Miller, the Chief Operating Officer from Bronx Regional Health Information, the Bronx Rio, and the amazing work that they're doing in New York to capture screening across the state and support for their 1115 waiver application currently. So we hope you'll join us. You can always attend our public meetings, which we have regularly. Check out the slide. And thank you very much.
So we do have a few minutes left here for some questions. Does anybody have questions? We'll go ahead and throw it to the audience here. I know I was telling them I had a couple of questions teed up, but I'll see if our audience members
have. Hi, thank you all for that. That was amazing. My question is, I'm just curious about, I saw a lot of providers and payers as part of the conversation, and I work at a payer, and I'm curious about the role of healthcare technology vendors in the conversation, because as a payer, you know, it's one thing to collect the data, but we're limited by our ability to store it based on our technology. I love what you said about storing it in an Excel spreadsheet, because sometimes that's our only choice. So I'm just curious if you have any insight into that.
I can start. I think some of the other panelists might have more here than I do. I guess the one thing I would say, so we have been in conversations with some of the larger EHR, EMR vendors, some of the other technology like front-end registration vendors, things like that. The thing that I'd say is they actually have, and I hope I'm saying this in a room, if somebody from one of those perspectives is in the room and wants to correct me on this, feel free. But a lot of this is built out. They've got the teams who have worked on it internally. There is an SDOH, module. There are the anatomical inventory modules or the detailed SOGI or race ethnicity questions to build into your registration system. It's that they're not the default currently, and it requires sort of an extra request, both to get the structured fields in, but also to make sure on the back end that they're mapping to all of the standardized terminology that's being created. And it's not that it can't be done, and it's not that they probably don't already have a programmed instantiation of that somewhere they could pull in. It's that it's not always being offered as the default. So the first question would be to ask. That doesn't always help, because if it's not the default, that means is there an extra charge, ? But I think for us, that's been one of the biggest sort of learning experiences, is that many of them already have these capabilities. You just kind of have to make sure you're probing and pulling them in.
We have one from online. Are any of you starting to address the proposed OMB race and ethnicity changes in any of your work?
I'll start with that one. So yes, When they issued or posted the Federal Register notice, they do ask for comments across the public. As I mentioned earlier in the presentation, OMB received more than 20,000 comments, and part of that process also include comments from the different agencies across the different departments. So they each have a representative from the interagency working group across. So each of the department has a representative, and if the department has a statistical agency, then technically you have two. So a lot of the discussion has been happening, and we, at least from a CMS perspective, we're looking forward to what that new standard is. But at the same time, we have to sort of be prepared and figure out, okay, which of our current administrative claims data or surveys or whatever you call a collection vehicle currently collecting race and ethnicity, and at what level, and if changes need to be made, what will it be? Will it be like from a current OMB standards to the new standards, or something in the middle to the new one? Or if we currently don't collect, how do we make sure that we set the stage to collect in the future?
And I think in addition to that, from an ONC perspective, we've been watching this as well. One of the things that I didn't get to mention in our presentation is that we also have the Interoperability Standards Advisory, also known as the ISA, and it's something that actually gets updated every year with input. So as this goes from being proposed and getting feedback and becoming the new standard, that'll be something that we look at and putting in our ISA.
I have one question. Vanessa, been involved with the Gravity Project way at the beginning. Excited, it was some of our more seminal work. We wrote the reference implementation. I'm very proud of that work. And I'm really interested in where this is going, obviously. One of the challenges that we're all going to have is consistency in data. Right, so you've all referenced different standards activities that could all kind of combine, perhaps, or be driven around SDOH. SDOH to me is like this one great unifying purpose. So I'm really hoping that that happens. So let me zero in on assessments in particular. If assessments can be standardized, do you think, well, do you think it can be standardized? Because that was one of the things that we were challenged with when that first RI was done. We wanted consensus from this larger group that held us functional knowledge about what would be the appropriate questions to standardize around. If we could standardize on the process with those assessment questions, that'd be a huge win, right? So I guess my question is, how do you see that evolving with the work happening on Gravity?
Yeah, I'm happy to take it, and also happy to hear from other panelists if interested. But when we think about screening instruments and assessments, there are a few out there that are pretty well known, right? Prepare, HRSN instrument. There's a lot of standard opportunities there. Gravity has done some work, and if you look on the implementation resources we put out this year, we went through and helped identify the sort of Gravity vetted questions that are across many instruments. And there's going to be, do I think that there'll be a standard instrument across the country? I think that communities need to figure out what's best for them and their population and their community themselves. I think that the process for capturing and the codes behind the questions are absolutely standardizable. When we talk about FIRE, we look at questionnaire and questionnaire response, which is used across a lot of different sort of survey tools, right? The questions aren't the standard, but the data behind it and the way to do it is, right? And so that's absolutely what our goal is. We're using questionnaire response, and observations to try to capture this data in a meaningful way to not only get at what was asked, what was answered, and what the options were that could have been, right? And understanding that context and also the order of the questions is all really useful when we get into questionnaires. But then the observations is sort of the what the need is, what those positive screens are. And I think all of that is very standardizable, whether we get to a specific instrument or certain communities standardize their instruments. We'll see. Yeah. Anyone else want to comment on that?
So we attempted to standardize some of the SVOH data elements as I presented through the post-acute care settings, right? Making sure we ask the questions consistently and what those response options are. And we are also trying to work on how can we do that beyond those 4 facilities that we currently collecting the data from. So it is definitely that's something where we're trying to make sure where we can standardize, we'll definitely do that. But how does that align with the rest of the industry? Then of course, it's a totally different question. But we're working towards that as much as we possibly can.
So, good job on an awesome panel. So really thank you for everything. My question is more for Meagan. I have actually 2 questions, one really light one and one like real question. So the light one is, I found it astounding that there were 20,000, responses to the, how does that rank? I mean, is that like up there or is that standard? That's the light question. The heavier question is somebody in the audience noted that her commercial payer, she's a commercial payer, and they don't have any place to store this data. So does CMS have that problem, or is the data? Do you have places to store the data? Do you have, if you can answer that, that's the heavier question.
So I'll start with the light question. I'm not quite sure, but OMB recognizes that they will get a lot of comments, and they did. And so they are actually, the latest update I received, as part of the process of updating the agencies, that they're going through every single comment. Some of them are form questions, so, a bunch of people get together, submit the same set of questions, but they do value the feedback that they're getting. They're making sure that they're getting the information out there to get that feedback, because it's an impact across the nations, across different industry, not just a specific few. In the last time they made the update was in 1997. So this is a big deal, and I think we're all excited and anxiously waiting for that. In terms of the data, as you all may know, CMS has a lot of data, and yes, we store them all. So I don't think the storage is the issue. The issue is how do we link the data, what we're using the data for, and what we're showing that data. And so there is definitely a lot, and we continue to collect new data, right? So we're just piling and piling and piling. But internally, we have what the chronic condition data warehouse, for example. That store a lot of the Medicare fee-for-service claims data, the post-acute care setting data, now Medicaid data, and a variety of other data sets as well. External individual can get access to the data, but it's mostly for researchers because they're clean in making sure that it's usable in a way that it doesn't create any issues for the users. But internally, we have various databases that store different types of data, the quality data, the raw claims data, health equity data, there's IT data. And so we are trying to figure out how all those data sets interact with each other. Not quite sure if I fully answer your questions, but yes, we have places to store the data.
Not on the CMS side, but to come back to the payer side, one of the things, and I was thinking about it as you were responding, Meagan, on just the infrastructure needed to manage all of this. When we were doing some qualitative work with the organizations who were responding about all the different data sources that they had and how they managed it, we were asking, who are your partners in the organization? What is your criteria for success to be able to pull off having any sort of infrastructure that is accessible and useful? And there were 2 that came up all the time. One was leadership, because it takes resources, so you need funds and so on. The second one, it was not the quality group, it was not case, it was IT. IT came up in every single discussion in terms of setting up the common data infrastructure, the data models, the access permissions, making sure it updated at the right cadence, data wasn't overwriting itself. And so I think, not underestimating the infrastructure that it takes to manage all of this in the background, be it at the federal level or at the individual organization level, and planning ahead for that this is an IT effort, an infrastructure effort. It's not just a sort of content of the data effort.
I would just want to touch on that as well in thinking about the foundational elements in our toolkit, because we try to think about the whole process of what it takes to set up a SDOH information exchange initiative. And one of those things is kind of bringing everyone to the table, and that includes. Hello? Yeah, thank you. Again, just restating just everything I've heard and going back to our SDOH Information Exchange Toolkit. And it is a resource for people to understand what it takes to set up a SDOH Information Exchange Initiative. And we do have that technical aspect to it. So getting to that point of really sitting down and figuring out what that technical infrastructure needs to look like. What are those things that need to be built? Where are things already in place? Where are updates that need to be made in order to do that information exchange of that data? Look for the recorded session.
Thanks for turning your mic on. Hey, I have one question that you guys sparked in that discussion, and I'm Tim Putcher from Michigan Health Information Network. We see an awful lot of confusion. First, people coming up to speed on ICD-10 Z codes, but then they drop right into another bunch of confusion around the LOINC codes and the observational data. Could you all speak on how you see that getting sorted out for particularly the health plans? Should they be collecting the Z codes, or should they be actually trying to go out there and get the raw observation data? Any points of view on that?
So I'll start and I'll look to Jawanna for an answer. I'm confused myself. But for a selfish reason, in terms of my group doing the analysis for the Z codes, the more we get the claims data through the ICD-10 Z codes, and that's the billing for CMS, right? We do collect that along with the HCPCS codes and other CPT codes, so on and so forth. So it's for CMS purposes, we do collect the ICD-10 Z codes, and that's how we capture the information, analyze the information. But for the LOINC,
Yeah, I think there's an interesting kind of conundrum here. The Z codes will be generated because that's what's going to be paid. So we have to make sure they're as effective as possible. One of the challenges with Z codes is they didn't have a denominator until very recently, and the G code sort of came out in the most recent announcement in terms of how to bill for the screening, and then you have the response in the Z code. But the thing I think sometimes we miss on is that it's not just the provider's billing that generates the screen and response data. A lot of plans are generating it themselves: case management, health risk assessment, pop health initiatives, and so on. And so you could variably have at the plan level a particular questionnaire, a response to that questionnaire, and a positive or negative screen. And that's where, that mixed in with the potential of HIEs and sort of intervention and service planning based on the more detailed data that you get through the particular screeners. You get temporality there. Is it 30 days? Is it 6 months? Things like that. I don't think, both because the plans generate data and because there is resource planning that may need to happen on the more detailed data, I don't think we want to write off the LOINC and the SNOMED and the clinical data codes. It's making sure that they flow more naturally into each other so that the payment can be processed, but the more detailed information is still available.
Yeah, thanks for adding those points. The thing that I was thinking about is exactly what you said, is just thinking about the use case. Like, what do you need the data for? Is it for assessment? Are you doing a referral? And there's different needs based on the question that's being asked and the answer that's needed. Mm-hmm.
Okay, great. Well, we definitely went over on time, but we weren't bumping up against anything. So that's great that we had such a interesting discussion here with the panelists. I want to thank all four of you for being here today and presenting on all of this great work that's going on at all these different levels. And just thank you all for sticking it out to the end of the day here. We are starting back up again in the morning. Breakfast will be out there at 8 o'clock. And then I think our sessions start up around 8:30. 8:45. See, there you go. Thank you. 8:30, it's up on the screen. And we've got still another lineup of great speakers tomorrow. And of course, we've got Vanessa, who will be back again for our last session tomorrow, talking more about gravity, as she said. So thank you, everybody. Have a good evening. And we'll see you back tomorrow.